Hello and welcome to our recorded webinar. My name is Ferry Tomaszyk, International Sales Manager and RehaCom Clinical Consultant with HASOMED Germany. I'm delighted to have you join me as I talk about cognitive screening and share knowledge on how to identify your patient's strengths and weaknesses efficiently and quickly with RehaCom. So this is what is on our agenda today. RehaCom at a glance, the 9 screenings for cognitive impairment in an overview, screenings in detail, deployment, processes and administration. This topic will have the focus and be the most detailed. Test evaluation, benefits and therapy module recommendations, and of course FAQs and their answers. RehaCom is perceived by therapists working in the field as a complete and flexible, customizable, computer-aided therapy platform. The most common and impacting cognitive deficits following an acquired brain injury or disease, such as attention disorders, memory problems, executive functions, and in addition visual field disorders and visual spatial neglect, can be treated efficiently and precisely with the system. The platform is primarily designed for treatment, and the system provides 28 auto-adaptive therapy modules. But what happens if, for example, a stroke patient can't operate a computer keyboard properly because of his hemiplegia? In this case, we also have a proven solution and offer a special patient keyboard with large color-coded buttons. RehaCom offers both in-clinic and in-home training licenses to allow for the greatest flexibility in rehabilitative treatment. Therapy is the same with both versions and is guided, prescribed by the clinician. But what about the essential importance to treat the patient in his mother tongue? Don't worry, we have made sure of that too. Our software has always more than 25 languages implemented. But as a first step, it's essential to get a picture of the brain-injured person's strengths and weaknesses. Particularly, you need to know what are the problems causing the greatest difficulty and how you can set up an optimal treatment plan. In answering the most urgent questions, you will be supported by the 9 RehaCom screenings. Here I show you an overview. RehaCom's screening battery consists of 4 short tests covering the core cognitive subdomains of attention, as well as 2 memory tests, a logical reasoning test, which is an important part of executive function diagnostics, and 2 visual field screenings. The screenings are commonly used for the early identification of individuals at potential risk for cognitive disorder. They may indicate need for further evaluation or intervention, and they are used to monitor the response to the intervention. Screenings don't provide definitive comprehensive diagnosis, so cognitive screening tests should not be used as a replacement for comprehensive neuropsychological testing. But it is common for clinicians to be uncertain as to whether a patient is demonstrating behaviors that suggest cognitive impairment. It is important to quickly assess which of these patients actually have cognitive impairment that may be contributing to functional problems. All screening modules deliver normative data in order to compare the patient's results with data of healthy persons of same age and gender. The screenings indicate the deviation from the norm value. The screenings are supposed to assist the therapist to find the right therapy modules. They can detect which cognitive deficit the patient may have and which degree of severity can be found. As a result, and this is of great added value, the system automatically recommends therapy modules that are most suitable to address the specific cognitive deficits of the client. Here are the 4 screenings supposed to measure the intensity and selectivity dimensions of attention. These tests are valuable in determining the baseline cognitive attention status, attention activation, selective attention, divided attention, and perceptual processing speed. The first screening is the alertness screening. Alertness is the basis for any attention performance and therefore the precondition for adequate action. This screening measures reaction times. The reaction times are measured under two conditions. The distinction is made between the tonic arousal, the general state of being awake without a warning sound, and the phasic arousal, which describes the increased responsiveness in anticipation of an expected event with a warning sound. Accordingly, two z-values are calculated. A distance from the average of the norm greater than 2 standard deviations indicates a very notable moderate to severe deficit. A deviation greater than 1, a notable but mild deficit. A distance from the average smaller than 1 standard deviation or better indicates a result in a normal range. Depending on the results, the therapy module's alertness and/or reaction behavior are suggested for the exercises. Before I walk with you through the other available screenings, I will show you this excerpt from the overall evaluation. The color-coded visualization of the deviations from the norm is highlighted by many therapists as being particularly valuable, especially by speech-language pathologists and occupational therapists. We get a lot of positive feedback. Thanks to the color coding, the strengths and weaknesses of the clients can be seen at a glance, and at the same time Z, T and percentile rank values are available. Using the screening selective attention, the ability to react under time pressure quickly to relevant stimuli is tested, as well as to inhibit behavioral impulses when a non-relevant stimuli is presented. The test is based on the well-known go-no-go paradigm. In random intervals, stimuli presenting either horizontal lines or vertical lines. When the stimulus with horizontal lines is shown, the patient has to press the Enter button on the PC keyboard or the OK button on the patient keyboard as soon as possible. When the stimulus with vertical lines is shown, the patient should not react. Two z-values will be calculated, one for the reaction speed and one for the reaction control. The screenings enables you to analyze a patient's ability to control impulse reactions by looking at the number of mistakes. The mean, median and standard deviation of the reaction times can provide information on the speed of the decision process. Additional information as omissions, outliners and anticipations are provided. Depending on how slow is the working speed and the degree of impulse control, for example the training module's reaction behavior and/or responsiveness are suggested. Divided attention is the condition of paying attention to more than one stimulus or to a stimulus presented in more than one modality. It is important for everyday life. Not often is someone engaged in just one task. Driving a car is a good example. The divided attention screening is an audio-visual test. The patient has to work on a visual and an auditive task in parallel. 5 circles with openings at changing positions must be observed. When a circle is closed, the patient has to press the Enter button as quickly as possible. Synchronously alternating high and low tones are presented. When the same tone sounds 2 times in a row, the patient has to press the Enter button as quickly as possible too. Accordingly, 2 z-values are calculated. Z-value 1 is calculated for the auditive divided attention. Standard value is the number of auditive omissions, which means the numbers of missed reactions to 2 consecutive identical acoustic stimuli. Z-value 2 is for the visual divided attention. Here the standard value is the number of visual omissions, the number of missed reactions to a relevant visual stimulus. If deficits are measured, the training's divided attention and/or divided attention 2 are recommended to exercise. Last but not least, the screening spatial number search, the numeric quadrat. The spatial number search screening module is used for testing a patient's basal perceptual processing speed and visual spatial attention. The patient has to find the numbers from 1 to 24 in ascending order on a grid. The consecutive numbers are not adjacent. Visual field search and exploration across the entire number field is necessary. The test can be used for screening of visual neglect or hemianopia as well. But two other more sophisticated visual field tests are available too, providing more precise information about neglect or hemianopia. I will show these tests later. Z-value 1 is calculated for processing speed based on the median of all search times. Z-value 2 calculates a linear regression of all search times. An increase of the regression line suggests that a patient's attention performance declines during the task. Z-value 3 is based on the comparison of average search times in the right and left half of the screen. An obvious slowdown on one side indicates either neglect or hemianopia. As applies to all the screenings, depending on the screening results, the system recommends appropriate training modules. Following this test, for example, the training modules Attention and Concentration, Vigilance 2 and/or Saccadic training. RehaCom screening battery includes also two memory tests to identify visual and verbal memory weaknesses called working memory and memory for words. In the working memory test, visual spatial memory span and visual spatial memory functions are measured. The task is also used to test the implicit visual spatial learning ability. During the learning phase, an increasing number of dots at different randomized positions on the circle turn red and fade. The task is to remember those dots and click on them in the same order. If the patient selects a sequence of dots correctly, the number of dots increases in the next sequence. In this case, the program is adaptive, adjusting the difficulty according to the patient's performance. If the patient makes a mistake, the level of difficulty is reduced. The screening ends after the patient incorrectly reproduces two consecutive sequences or after a maximal duration of 7 minutes. In the working memory screening module, one memory span Z-value is calculated. Similar to the Corsi block tapping, the visual spatial memory span is measured by the maximum length of the memorized dot patterns that can be reproduced immediately without errors. RehaCom's training module, working memory, in this case it has the same name, and the memory strategy training module are good training options. The memory for words screening tests an aspect of the verbal memory according to the paradigm of recurring characters. Words have to be read, learned by repetition and stored in long-term memory. The actual test is preceded by a pre-test and a test run. The pre-test is to ensure that the client is able to distinguish words in general, discrimination of words. Two words are presented on the screen simultaneously. The client must decide whether the words are equal or different. In the second stage, the actual test, the client has to recognize recurring words. The client will be shown one word at a time on the screen. He/she must indicate whether this is the first time the word has appeared or whether it has already appeared before. This test requires the client's long-term memory. A Z and T value and percentile rank for the verbal learning ability will be calculated. For the rehabilitation of the affected abilities, the RehaCom therapy modules memory for words, figural memory, memory strategy training, or verbal memory are suitable. The logical reasoning test is an important part of executive functions diagnostics. The term executive functions is an umbrella term comprising a wide range of cognitive processes and behavioral competencies which include problem solving, planning, reasoning, sequencing, decision making, and other competencies. The screening is designed to identify the ability for logical conclusions by completing a logical sequence. The client has to figure out relationships and patterns between objects. If a client scored below the average, then the corresponding training of the same name logical reasoning and/or the training module planification is recommended. Let's turn now to the visual field tests with a few introductory remarks. Impairments of vision, visual spatial perception, and visual spatial attention are common results of brain injuries. 20 to 30% of patients with an acquired brain injury have visual problems. About 60% of those patients have restrictions in the visual field. The visual field refers to everything the eye can see in the central and peripheral vision when the eye is focusing on a specific point without moving the head. Visual field impairments include also hemianopia, the loss of half of visual field, quadrantanopia, the loss of a quarter of the visual field, and scotoma, a partial area of blindness in the visual field. Moreover, a visual spatial neglect is a relatively common attentional disorder resulting from unilateral hemisphere damage, most commonly from a stroke but also from other conditions such as tumor or multiple sclerosis. Patients with neglect pay less or no attention to the space on the opposite side to their injury, mostly the left side in cases of right hemisphere damage. A visual field test is a method of measuring an individual's entire scope of vision. The visual field testing is used to detect signs of conditions affecting the optic nerve and the occipital cortex, where this information is processed into vision. Tests are also used to identify a visual spatial neglect in patients with unilateral brain injury. Campimetry is an excellent test for use in the neurological clinic, rehab clinic or outpatient center as an alternative for cost-intensive perimetry applied by ophthalmologists. With the campimetry screening, the field of vision can be examined binocularly or monocularly with a central fixation point and a stimulus appearing in random intervals at different positions in the periphery. The visual field screening you see on the right side measures the visual field under selective conditions, measures fixation accuracy and sustained attention. The test will map visual field deficits and neglect symptoms. An increase of errors or reaction times during the course indicates fatigue and declining concentration, and has to be considered as an intervening variable in the interpretation of a visual field deficit. In this test, the client will be asked to focus on a circle in the center of the screen. He has to press the Enter button immediately when he sees that this circle fills with color, and he has to indicate when the line from this circle with another circle on its end appears. He should not react if there is no circle at the end of the line. In both tests, the patient must look straight ahead at all times in order to accurately map the peripheral visual field. To control the fixation, a fixation point changes randomized color or shape. The change should be confirmed as rapidly as possible. It is recommended to use a maximal large screen in order to offer a sufficient visual angle area. In addition, we also offer chin rest for head fixation. The chin rest allows a reproducible position in front of the monitor, remaining the same throughout the test or the visual field training. In the results screen, you will have a scoring and a visual field mapping. Both screenings allow an imaging of visual field deficits, neglect symptoms, and reading disorders that is sufficiently precise for therapeutic indications. The visual screeners can be completed by a trained non-vision specialist clinician, but it does not substitute for a full evaluation by a vision specialist, an ophthalmologist or neuro-ophthalmologist. However, it allows us to identify appropriate candidates, make needed referrals, opens up the line of communication between the therapist and the vision specialist, and most importantly, the screenings give guidance for intervention. There's a substantial amount of evidence that patients can be supported to compensate and adapt to visual field loss using a range of strategies and methods, as systematic adaptive exploration exercises, saccadic eye movement exercises, visual scanning training inclusive optokinetic stimulation in case of neglect, and re-establishing assigned perceptual functions by intense light stimuli. Depending on the test results, the corresponding training modules, saccadic training, exploration 2 or restoration training, are recommended to exercise these techniques. Representative for all the 9 screenings, I show you as an example the view of the spatial number search screening result. All other screening results will be displayed on a similar way. In the colored middle you see the graphical representation. Statistical T-norm, Z-norm and percentile rank are shown across the top with the 50-0-50 column representing the average performance of a sample group of healthy people. The patient screening results are shown as gray bars which begin at the Z-norm 0 and stretch either to the right, indicates above average, or left means below average. A longer gray bar represents a greater deviation from the norm. The background colors indicate the extent of the performance deficit. The red area represents 2, 3 or more standard deviations below the norm, a very notable moderate to severe deficit. Yellow represents more than 1 standard deviation below the norm, a notable but mild deficit. Green marked is a result in the normal range. The distance from the average is smaller than 1 standard deviation or better. Screening results are summarized to the left of the graph, the discussion section. The screening module name and the tested functions are shown along with the screening date and the summary of results. The recommended therapy modules following the screening result are shown bold written at the bottom. In this example, the modules attention and concentration and exploration. On the right hand, you find the print screening button. This button converts the displayed results into a PDF file that can be printed or saved. The Details button displays a more detailed analysis of the screening results. The Start Therapy module button starts the corresponding therapy module indicated by the screening. This button is only visible when a deviation from the norm is measured. All results are stored in the patient's database. On this way you have the option to evaluate the results later again in order to create a specific therapy schedule. Okay, now I will answer some frequently asked questions. What should I consider when administering a screening? Each screening starts with a brief exercise to familiarize the client with the task. During exercise, the system gives correct wrong advice. The therapist's task is to make sure all has been properly understood. Once the exercise is completed successfully, the actual screening is performed. There are no more advice or feedback. The therapist should no longer give any assistance. You are probably wondering how long the screenings are. Each screening has its own specific minimum duration corresponding to the respective test goal. The screenings last between 4 to 10 minutes, one is up to 15 minutes. 2 screening lengths are adaptive, depending on the patient's performance during the screening. The maximum total length of all screenings is about 1 hour. You may ask, can I do all the screenings in one session? Please take into account always that each patient has an individual tolerance level. The answer to this question depends on the constitution of the patient, the phase and the goal. In an early rehabilitation phase and in geriatrics, performing the screenings one after another may overstrain the client and may lead to excessive fatigue. The results are then not very reliable. Only 1 to 3 tests are made appropriate in one session in this phase. In a late rehab phase and/or planning the transition to professional reintegration, all screenings may be indicated to perform in one session. Another frequently asked question is about screening's order. Due to the fact that a good working attention level is the base for all continued cognitive therapy, attention screenings have priority within the order you should proceed with the screenings. Particularly, please keep in mind, even if patients report about memory deficits, it could be due to an attention deficit. However, there's a special circumstance to consider. By that I mean a presumed visual spatial neglect or a visual field impairment. In this case, you may verify your guess by using the visual field screening campimetry at first. The attention screenings themselves should be carried out hierarchically, starting from basic attention level functioning up to higher level skills. Accordingly, the attention screening should be carried out in the following order: alertness screening, followed by the selective attention screening, then divided attention screening and spatial number search screening. Afterwards, working memory, memory of words, logical reasoning, campimetry and/or visual field. To the next question, do I always have to do all screenings? At least the following screening should be performed to determine a baseline cognitive status: alertness, divided attention, working memory, memory for words, and logical reasoning. What's an appropriate frequency to repeat a screening to determine the therapy progress? In order to monitor the response to the intervention, you can repeat a screening. It is recommended to repeat the screening modules after 10 to 12 therapy sessions at the earliest. If the test intervals are too short, maybe no therapeutic success can be measured. Take into account as well that testing with the same screening leads to learning effects and may falsify the test results. Interferences. It is the goal of the therapist to get the best possible picture of the patient's current functioning. But several things can interfere with this goal, such as if the patient is excessively tired or fatigued or has sudden unexpected sleep attacks, not motivated to put forth their best effort, the patient is very emotional, distraught, or has a severe psychiatric condition. The client could be under the influence of medications or substances which interfere with cognitive functioning. Patients should let the examiner know if they anticipate that any of these issues are likely to interfere with the evaluation. What age range are the screenings for? All screenings deliver normative data ranging from 6 to 80 years. Finally, the question how to get help on demand. Detailed information on the screening modules are available at your fingertips. Mark the screening in the selection. With a right click on the mouse button, the help option appears. Click on it with the left mouse button and a PDF will be opened with all information about applications, target group, structure, implementation, duration, data analysis, and literature. Thank you for your interest and your sustained attention. Stay safe and healthy. Thanks a lot.